Hi, good morning, guys. No, yes, please. Okay, that'd be great. I will move as quickly as I can, so please bear with me, and if there's anything I can clarify at the end, please come find me. I'm going to be focusing on depositional disorders and conditions that have pigmentary implications, and they'll kind of merge nicely into each other. No disclosures. I think there should be some sort of model in our mind of how we think about approaching a patient that we're going to use lasers for to address a cosmetic concern related to their systemic condition or their underlying disease. We want to make sure that you're going to improve some aspect of symptomology. We want to make sure we're improving appearance because, after all, that is why they're coming to us at the end of the day. We have to try to make sure we're not exacerbating their disease or flaring it, make sure that we're associating this in sort of flow with their medical therapy. If we're going to do something and we're going to put them through a lot of trouble, I'm not putting pulse dye in that category, but something like an ablative laser, we want to make sure that we're going to give them a durable remission or at least a pathway to maintaining that. Make sure that's somewhat cost effective. Not everything will be covered under insurance. We're not in that place in this world yet. And then we will all operate with what we have in our clinics. So you want to set clear expectations as to what you can deliver and how long it's going to take. And those are hard because there's not a lot of data on managing many of these conditions. I'm going to kind of go through these, as many as I can, and we'll start with amyloidosis, which is kind of a cheat condition because its systemic implications are small, maybe 1 to 7%. I'm talking about macular and lichen amyloidosis because nodular, as you can imagine, is not going to be laser amenable that easily. Lichen and macular, I think, is a good one to think about because we're talking about something that's largely upper dermis, epidermis related. We're dealing here with a protein that's coming out of degenerated keratinocytes. So if you can remodel the keratinocytes with your laser therapy, you can actually hopefully remodel the course of the disease. It also coexists with other conditions that we see quite commonly: atopic dermatitis, prurigo nodularis, notalgia paresthetica, connective tissue disorders. So it's not just that you have to clinically make that diagnosis, but you might notice it in the context of other things. One of the studies that came, and I will sort of review a lot of the literature because I think this is what's going to help us make calls in our clinic. This is fractional carbon dioxide, and they picked out 24 patients both that had histologically confirmed disease and then 24 controls. They did 4 treatments, 4 weeks apart. These are patients that had disease for several years, so this was not new onset. They had tried and failed many different things. What they found in their study was statistically significant improvement in the pigmentation, the rippling, and the thickness. When they looked at patients that had amyloid and they did biopsies of those patients and then did PCR analysis, those patients also had elevated IL-31 and IL-31 receptor values. And when they did these treatments, those values after rebiopsy actually came down. And we know in the med literature that there's a lot of data on IL-31 and itch, and there's drugs out there now to manage that. So I think this is an interesting implication to think about lasers actually as remodeling some of the cytokine pathways. Erbium, you would imagine, well, hey, I've got this in my clinic. I don't have a CO2. Will this work? Not as big of a patient pool. Again, 10 patients. They did the same thing. They did a histological confirmation, but there were no controls in this, so there's not a good comparator here. Again, 4 treatments, 4 weeks apart. Again, statistically significant improvement in pigmentation, reduction in the rippling and thickness, but I don't think to the same extent as we saw in the CO2 study. Again, a reduction in the pruritus, so I think that is where we're getting symptom improvement for patients that have this. I think patients, some of the literature has mentioned, could there be enhancement of what we are doing by topical drug delivery? So could we throw on some topical steroid? Could we throw on some tranexamic acid for pigmentation? So these are some other things to think about as you consider doing this, and we don't have literature or even enough of patient population on this. 1550, I love my Fraxel, or sorry, I can't say that, my non-ablative resurfacing device, and I use it quite a bit. So can we use this? And this was a study that looked purely at treating lichen amyloidosis. Again, a smaller cohort of patients, no controls, fewer treatments, so not exactly the direct comparison with your prior studies here, but again, improvement in pigmentation, thickness, some of those bumps that you're seeing as well. Again, reduction in that pruritus, which is great. And they did a post-analysis as well for the histology, and again proved that that epidermal thickening that you see when you do lichen amyloidosis biopsies, those amyloid deposits came down as well. I think what I've loved about this session this year is that there's been a lot of talk about using the picosecond lasers and different applications of that. I think our Asian colleagues are doing amazing work in that. Here's a study that looked at using the picosecond ND-YAG for lichen amyloidosis. So the mechanism of action here is a little bit different. With our non-ablative and ablative resurfacing, we're potentially trying to extrude some of that bad protein that's in the skin. We're trying to reset the keratinocyte progression pathway, reduce the production of that protein that's getting degenerated and dropping into the dermis. Here, we're actually targeting more the melanophages, the pigmentation, maybe producing some LIOBs and some plasma that's going to create some resurfacing effect and again reset that keratinocyte change and evolution and pathway. So this is slightly different. There was some improvement in the pigmentation and reduction in the rippling. This was all dermoscopic, so I don't think the data is as strong as the other ones, but something to keep in mind if this is what you have and you have a patient that doesn't want to go through a resurfacing procedure, you have another option in your back pocket. This was a comparative study that looked at several options. They did PDL, they did Q-switch 1064, they did CO2, and then they combined Q-switch 1064 with CO2. And what they found was that the CO2 just did very, very well with no added benefit with the Q-switch. So again, supporting, I think, what the data of the prior studies have shown you. And I think if you have that in your pocket and somebody wants to jump in into that with you and are willing to sort of go through some of the recovery and the healing, that's the best way to go. I think there is some slight chance of hypopigmentation, that's always the risk, and then prolonged erythema, which we know with any of our resurfacing procedures. I love treating xanthelasma. I enjoy it a great deal. This is a review that came out of the Plastic Surgery Journal. There's lots of ways to treat this. Surgery is probably the most definitive. Often when you use lasers, there's a chance of recurrence because some of those lipid-laden cells are sitting in the muscle, and that will come right back. So if you really have a patient that's all about, I want it done and I want it gone, you should let them have an oculoplastics consult for sure. But lasers can be effective, and in a study that looked at about 30, 40 journal articles that have done some work on this, they showed that a quarter of patients achieved more than 75% improvement when using a laser, and CO2 probably was the standout winner in that. But do you do fractional or do you do fully ablative? And this particular study showed that you can get probably better improvement in the thickness and the height when you use a fully ablative laser, but probably patient experience and the actual overall difference in the change in size is probably better when you use a fractional laser. So if you have a fractional laser and you don't want to do the fully ablative and deal with some of the recovery risks like scarring, ectropion, then you can go down the fractional pathway. It might require more treatment, so always when you're making that trade-off of something that's less intense, you're making that explanation that you might need to come back to see me a few times around. I love my 1450 diode. This is a dinosaur device that sits in my office. It came in through my predecessor, so I'm very, very fortunate to have this. If you have this or can find this, this is a wavelength that very beautifully targets fat in the skin. We have a laser now that's the 1726 nanometers that are out there, and perhaps someone will have the chutzpah to go and check whether that's going to be a good treatment for this. The 1450 diode was initially described by some Asian teams in 2011, and this was a follow-up paper that came out in 2021 that looked at being a little bit more aggressive and at fairer skin types, and they did infiltration with lidocaine with epinephrine and then used this device to sort of pulse over and pulse stack a few times. And what they're looking for in terms of their endpoint is kind of this grayishing change and a little bit of shrinkage of the tissue. You have to be cautious though, you don't want to bulk heat because here you can get scarring if you do that. But a beautiful result after 3 to 4 treatments with these patients. Very minimal downtime, some redness. Occasionally there might be a tiny little blister that forms, but most of these patients do excellently. And I've done this as well for patients. Those are a little bit thicker and larger lesions. This was one of my patients. We did 4 treatments 6 to 8 weeks apart. I'd say there's probably about an 80% improvement. He was extremely happy. I think the goal here is how do you get your patient to the finish line where they are comfortable. He was able to go back to work every day after treatment. He did what he needed to do, and it was no fuss, no muss, which I think if we can do that, that makes life so much easier for us and for them. I think it's interesting, again, to bring back the Q-switch or the picosecond lasers, the 1064 here again. This was a paper that came out of the Asian literature. Their endpoint here was hitting purpura and a little bit of pinpoint bleeding. I get a little anxious when I get to that endpoint. I don't think I ever have really. But if you are having this in your arsenal and this is what you want to try, you could do a test spot or pick one lesion. You want to pick an area where there maybe is a little bit of laxity so that if you do have a bit of scarring, you're not going to have, you have a little bit of wiggle room, if you will. I think that's sort of here in the medial eyelids. If you see in both of these pictures, that's where they've shown. Patients did quite well. Another option to utilize. Again, you have a better response with more treatments.
And I'm assuming they use an eye shield for this. I mean,
yes.
For all of them they do, yeah.
Yes.
But this one in
I'm
particular.
assuming we know this, but if we don't, yes. If you're going to be operating in these areas, please use an eye shield. CO2, 1450 diode, 1064, that's a really good point. Migrating to a non-Langerhans cell histiocytosis, necrobiotic xanthogranuloma, I think this is a really tough thing to treat. I have one in my clinic right now. I'm trying all sorts of different things, and I don't have a great endpoint yet for that. But CO2 probably has been shown to be the most effective in terms of giving you an outcome and reduction of that kind of pigmentation variation that happens, that reddish-brown color, but also some patients can get kind of a yellowish appearance from some of those lipid-laden histiocytes as well. This is a really interesting paper that came out in 2014. This is out of Jeffrey Dover's and Kenneth Arndt's group up in Massachusetts. One of the byproducts of all this inflammation from this particular condition is that you get melanin and hemosiderin, and that can lead to sort of reddish-brown appearance on the skin. And so they did a trial of several different lasers to address this, and the laser that sort of won out was their Q-switch 650 nanometer, which is on an older Q-switch device, which is a very good one. I think about other wavelengths that we now have in our arsenal, like the 670, the 694 for those of you that have a ruby laser, or the titanium sapphire lasers that are the 730, maybe the 785, although I don't think that will work as well. They defocused the beam to kind of get a cloudy white appearance as their endpoint, and they did 2 or 3 treatments. And I think this is a beautiful result. So I think a little bit of this as a, think about what you're targeting in the skin. You're targeting melanin, you're targeting hemosiderin, and kind of that sweet spot of trying to address that is actually the 660 to 680 nanometer wavelength. And the 650 here works beautifully, but if you have a 670 in your pocket, a 730, you'll be, I think, in a good place. So now jumping kind of into full pigmentary, because that was kind of a transition case for us. Lichen planus pigmentosus, I think there are some conditions in dermatology that are hard to treat. This is one of them. Hair is probably the other one. I think the big overarching concept for this, as I'm just looking at the time here, is to think about making sure that the disease is quiescent, it's quieted down, you've treated the inflammation, and then you slowly start to chip away at the pigmentation. So they pre-treated this patient here with topical betamethasone, hydroquinone. They did a triple compound as well, and they did 28 sessions every 2 weeks of a very low fluence Nd:YAG toning. I wrote the settings here twice just because I want to really emphasize it, but I think the key here is, again, slow and steady for these sorts of patients because you don't want to reflare disease. In this particular one, again, you want to make sure that you're pre-treating with lightening agents. You want to avoid pulse stacking here. I think it's nice to know that the same mechanism can work in darker skin patients, and I think that's why I wanted to present this particular case. But again, concomitant therapy with topical lightening agents is necessary. And again, making sure that your disease is quieted down. Here again, they used a very low fluence, large spot size. The prior study used a 6 millimeter, here's an 8 millimeter. So again, pushing the idea of low fluence. And I've heard that said here in many different talks, and I'm going to start thinking about that more and more for my practice. This is a first study that I found that was talking about picosecond for lichen planus pigmentosus. Here, this patient was on tacrolimus and hydroxychloroquine, both of which are known to be good medical therapies for this condition. And then they did, what was interesting was a toning pass, and then they followed that with a fractional pass. They did 3 treatments, and I think they had a really nice result here. I think fractional is tough from some of the talks I've heard. I think there is some tendency to trigger inflammation, and then you could potentially re-trigger the disease. So I would maybe have some caution in utilizing your fractional handpiece if you do have one, but something to keep in mind if you want to give it a try. This was an interesting case that came out that looked at initially using the 1064 Q-switch Nd:YAG. They hit kind of a plateau point in their therapy, but the patient continued to be troubled by her pigmentation. So they switched to the 785 titanium sapphire handpiece and had continued improvement, utilizing also post-treatment hydrocortisone, which I think is an interesting thing to do in patients with skin of color when you're doing these kinds of therapies. Is 3 to 5 days of a good topical steroid after laser just helps to quell some of that initial inflammation, so you don't end up with some of the PIH that you're then tackling and chasing down. One of the things they did mention in this paper, which I think is a good point, is that the 785 can be particularly caustic to that basal layer and induce a pretty potent effect on the pigment cells. So you want to be careful to not induce dyschromia and being too aggressive, and try to stay with low fluences. Again, with these devices, I think caution and going slow is really important, and a lot of the literature suggests that. I think a lot of the talks in the sessions have suggested that as well. I don't want you to forget medical therapies, so oral tranexamic acid, the topical JAK inhibitors, oral isotretinoin. These are things that are still part of what we should be doing and thinking about to help patients maintain stability while we try all these different devices. Minocycline-induced pigmentation I just felt was like a good one to keep in the books because I I think we're veering away a little bit from minocycline with all the new therapies that are coming out for acne, but it still is out there and may come in around, and you may see pigmentation induced from other sorts of drugs and therapies, so the principles carry over. I think here what I just want to summarize is I think the 755 works optimally for that. Here they started with monotherapy and a single treatment, and you see a beautiful result. And then I have started doing this for tattoos, and I think it works beautifully also for this sort of drug-induced tattooing, if you will, which is combination Q-switched or picosecond lasers with a non-ablative fractional resurfacing. And you can just, again, provide an opening, if you will, to extrude some of that pigment through the skin and not just have it kind of all go through the lymphatic system. So you have many ways, again, of combining things. And now with fractional handpieces with some of our picosecond and Q-switch devices, I think adding that on as well is also an option here, because this is not inflammation, this is deposition, this is something sitting in the skin. So we have a little bit more leeway to be a bit more aggressive here. So just to kind of summarize, continue medical therapy, try to get quieting of your disease before jumping into to laser therapies for your medical conditions. I didn't say this a lot, but I will say it now, at least to finish up, is that test spots are helpful, and I still do them quite a bit. I think for all of these patients, on the get-go, you should say multiple treatments. It's so hard. We don't have enough data. We don't know where it's going to take us. So they should be ready for a journey with you. Skin of color patients need more treatments on the whole anyways, and so that should be stated on the front end as well. In pigmentary disorders, avoid high energy, go slow, be careful with your fractionated devices. And the rarer wavelengths, I think we should try to see how, if you have them in your arsenal, where you can use them. If you have any questions, please feel free to ask, and thanks so much, guys.